Good afternoon, everyone. And a very warm welcome to our respected guest, Honorable Chairperson, our panel of experts, and my dear colleagues. I am Dr. Lutfunda Ramnesha. On behalf of Bangladesh Specialized Hospital and the organizing committee, I am truly honored to welcome you all to today's PME session, arranged in observance of World Thalassemia Day 2026. The global theme of World Thalassemia Day 2026 is Fear and No More, Finding the Undiagnosed. This year, massive emphasizes the importance of identifying undiagnosed thalassemia patient, increasing awareness, ensuring early diagnosis, and providing proper support and support for individuals and families affected by thalassemia. Today, we are deeply privileged to have with us our Honorable Chief Guest, Engineer M. A. Motin, President of Bangladesh Thalassemia Committee and Hospital, for kindly gracing this occasion with his valuable presence. We are honored to have our respected Chairperson, Professor Brigadier General Mahmoud Mustafi Sir, Chairman, Academic Research and Publication Committee of PSH. We are also honored by the presence of our respected special guest, Dr. Ahmed Jahid Hossain, Managing Director of Bangladesh Specialized Hospitals, and Dr. A.K. Ekramul Hossain, Executive Director of Bangladesh Thalassemia Committee and Hospital. Our sincere appreciation goes to our keynote speakers, Dr. Mafruha Akhtar, Associate Professor, Department of Hematology of Bangladesh Specialized Hospital, and Consultant of Bangladesh Thalassemia Committee and Hospital. And our another keynote speaker is Professor Dr. M. A. Khan Sir, Senior Consultant, Department of Hematology of Bangladesh Specialized Hospital, and Advisor of Bangladesh Thalassemia Committee and Hospital. We also convey our heartfelt appreciation to our scientific partner, Bangladesh Thalassemia Committee and Hospital. We are equally grateful to all our panel of experts. Today, our panel of experts are Professor Dr. A.N. Nasimuddin Ahmed Sir, Professor Dr. Hosniara Devi, Dr. Muhammad Tawfiq Sir, Professor Rejaul Karim Kajol, Dr. Jebun Nahar, Professor Dr. Maliha Rashid, Professor Dr. Narayan Chandra Kundo, Professor Dr. Israt Jahan Laki, Professor Dr. M.D. Sohailul Islam, and Dr. M.D. Mudlamur Rahman Sir. So, I hope today's discussion will be highly informative, interactive, and beneficial for all. Once again, thank you everyone for joining us today. Now, with the permission of our Honorable Chairperson, sir, please kindly invite us. I would like to invite Professor Dr. Mahmoud Mustafi Sir to say something and inaugurate the session.
Bismillahirrahmanirrahim. It's my immense pleasure to be in front of you, the very legendary personalities of the field of thalassemia care, Engineer M. A. Motin and Dr. Ekramul Hossain. Also, deeply sincere thanks to Dr. Mafruha and Professor M. Khan. This thalassemia, I have not, in fact, I didn't know that Thalassemia Committee is doing so much activities to prevent and to give services to the these very long morbid conditions. You'll be surprised to know that this committee has done a nationwide survey to document the percentage, the incidence, the prevalence of this thalassemia disease in the whole country, which most of the subjects, most of the our professionals couldn't do that. And to register the incidences, they have not only done the hemoglobin, they have done the electrophoresis of the patients. And they have their documents that has been published in the national literature. So this is a very great achievement, I must say, for the whole nation. In fact, most of in our country, we are always lagging behind to make a registry, but they have done an excellent job. And not only that, they are maintaining almost free services for the society, for the deprived populations in their hospital, giving the investigations and the treatment facilities like blood transfusion and others almost free of cost. So in fact, I'm going to hats off to you. You're doing an excellent job. So it's my privilege, ladies and gentlemen, to inaugurate this such a beautiful session. And I'll be happy that I'll be more confident that our junior doctors will be much benefited after this very grand presentations. So without much words, let us this continue the sessions. The session is open.
Thank you, sir. Thank you, sir. Now, with the permission of our honorable chairperson, I would like to invite our keynote speaker, Dr. Mafruha Akhtar, to proceed with her presentation on overview on thalassemia.
Thank you so much.
Thank you so much.
The moderator, for nice introducing me. And I'm very glad and honored to be here in front of you. Especially, I was thinking that PSH is such an immensely big institution now in private sector that they have all the specialties. I hope that multidisciplinary team or specialty doctors will be appearing here very soon. And thank you very much those who are listening through the Zoom meeting, I think. So I will be talking in next 20 minutes on the overview of the thalassemia. So, thalassemia. I'm Dr. Mafruha Akhtar. I'm Associate Professor of Department of Hematology at Dhaka Medical College Hospital, as well as the consultant of Bangladesh Thalassemia Shomiti Hospital. So moving. So these are the institutions from where I was actually get trained myself. My school period was in Municipal State College. Then I was studying in Dhaka Medical College Hospital, and finally, after doing the FCS in hematology, I took special training and fellowship training on bone marrow transplantation in UCLA and Mass General Hospital, USA. Some appreciation here. And today I'll be basically talking on the incidents, the clinical presentation, how the thalassemia patients usually present to different departments, not only to us, the hematologist or internal specialist. So then I will be talking a few words on the pathophysiology, phenotype and phenotypic relationship, how it occurs and how it turns into the clinical course, the diagnostic facilities, what we have, and treatment outline I will give. So there is not to be disclosed, but I'm a monitoring consultant and UTS for Bangladesh Thalassemia Society, Shomiti Hospital. So what is thalassemia? This is a group of congenital anemias. And this is such an anemia that is deficiency of synthesis of one or more globule subunits, the normal human hemoglobin, which is the primary defect in the hemoglobin formation. And that is usually a quantitative defect. And structural variants are also leads to quantitative reduction of the normal hemoglobin production, thus leading to alpha thalassemia, beta thalassemia, gamma thalassemia, or alpha beta thalassemia, or delta beta thalassemia, or other structural defects. So this is a significant public health problem. Since it is 71% of the 229 countries, this is an affected and problem, and this problem is worldwide present. So about 358 million person in the world carry this genetic mutation called thalassemia, and about 1.5% of the global population carries the beta thalassemia gene. That is the 90 million population in the world, and approximately 1% of couples are at risk of having this thalassemia-born disease, children. And 5 to 20% are alpha thalassemia carrier, and 1.3 million people worldwide have severe thalassemia. Here I want to mention that alpha thalassemia carrier are much more prevalent than beta thalassemia or other structural defect hemoglobin disorder. But this is not addressed because it is not diagnosed readily by hemoglobin electrophoresis. Geographical distribution is shown here, and the global burden is more than 60,000 new cases of thalassemia are born each year. And basically, Mediterranean basin, especially Middle East, Indian subcontinent, Burma, Southeast Asia, and including our countries, we have a burden of thalassemia carrier and also the disease. So estimated annual worldwide number of birth of the thalassemia children is 22,000 or more for beta thalassemia major, 19,000 plus for E beta thalassemia, and 9,000 plus for hemoglobin H disease, which is a variant of the alpha thalassemia, and 5,000 plus for the hemoglobin birds hydroxyfetalis, also alpha thalassemia. So Italy and Greece has more than 10% carrier once upon a time. Bangladesh, we have the 10 to 20%, 12% carrier in some areas, and for which 5,000 to 8,000 new cases, that is the thalassemia patients are being born each year. This is the estimated number. Actually, we don't have the nationwide actual data. But thalassemia carrier are much more higher in some districts like Rangpur and Dinajpur. This is 17 to 20, up to 27%. So we are doing research in the North Bengal, finding out the hemoglobin E disorder between the tribal population and the non-tribal population, which is funded by the BMRC. We started the work at the Dinajpur, Rangpur, Thakurgaon, and Panchgarh. Recently, we have been there for the at Rangpur in University in this month, and then we went to a very tribal village at Dinajpur. Then we went to Thakurgaon and Panchgarh. In our team, Ikram Bhai is here. He went to us with us, and Professor Ine Khansar, you can see. We went to Thakurgaon and Panchgarh to collect the data and to make the awareness among the students and general people. So now I'm going to elaborate a case history of a lady. A 25-year lady presented with a repeated blood transfusion since 20 years of her age while she was pregnant. And she was apparently healthy before. And when she was referred to hematologist, the hemoglobin electrophoresis revealed that she had E beta thalassemia. So while the part of the counseling, when she was informed that you have some disease that is present since your birth, and she denied to have this disease because for her 20 years of her life, she never had blood transfusion or had no problem. So this is a common scenario when the patient or the parents are informed about their disease. First of all, many of them deny their genetic disease, which means that they usually says that there is no person in our family having this. So why I would have this? So this is the embryonic and fetal hemoglobin, which turns mature hemoglobin. I will not go in detail. But there is a very tight regulation between the hemoglobin alpha and the beta gene, because alpha and beta, two alpha and two beta genes are necessary for making the hemoglobin A, which is our normal hemoglobin. And they are located in the 16th and 11th number of chromosome. Deletion of 4 genes causing alpha thalassemia, which is not compatible with life, But when three genes are deleted, this is causing alpha thalassemia or hemoglobin H disease. But when there is a point mutation in beta thalassemia, beta globin gene, there is beta thalassemia or some other variants. There also may be gamma delta or other thalassemias, which are much less than beta thalassemias. So this, many of you know this, that this is the pattern of inheritance of the thalassemia or any autosomal recessive disease. So there is possibility of 25% of being born of the thalassemic children if the both parents are carrier for this genetic mutation. So this is the steps of the globin gene synthesis. You know that this is very strictly maintained in our body. And not only the globin gene as well as the alpha gene, these are all very much tightly regulated and producing the transcription, processing, splicing, and translation procedure. Then only the beta globin gene is produced or alpha globin gene is produced. And if there is some mutation in this area, this will produce either beta plus or beta zero thalassemia, which means beta zero means there is no beta gene is producing and making the patient total lack of the hemoglobin A. But beta plus means there are some mutations that causing some of the hemoglobin beta globin gene is producing, making the patient some form of the hemoglobin A is present. And this is the point mutation of the most commonly seen in the beta thalassemia. You know that actually I don't want to go in detail, but variants of the hemoglobin are produced during the missense mutation or nonsense mutation or frame shift mutation. If there is a silent mutation, then there is no clinical problem identified. So nationwide carrier detection was done first in back in 2020 or this is the before, but 2024 another study. So this study was done by nationwide detection of the molecular characterization of the beta thalassemia E variant in Bangladesh population, and the number was 1877. But recently, after 2024, the nationwide the study again was done, which includes much more patient. They are not patient actually, healthy carriers. So to detect among them who are the carriers, we have found out that 11.4%, right? 11.4%, which is still under process of publication. That's why I could not show you the publication data. So this is the common mutation of the beta thalassemia gene. There are more than 200 types of the point mutation maybe caused by the beta thalassemia, but here we can mention only few. So why these patients get anemia? Because pathophysiology is the globin chain imbalance due to less beta globin chain is producing. What happens then? The beta globin, when it is less in amount, the alpha globin, they are much more, meaning excess of alpha chain. This causes triplet formation, quadruplet formation. That is the alpha 4. So alpha 4, this is toxic for the cell, and this makes the cells ineffective erythropoiesis. That's why hemolysis is causing anemia. So excess alpha globin causing ineffective erythrocytosis, erythropoiesis, immune removal of the cells, mechanical removal, as well as all of this causes hypercoagulability, making the patient vulnerable for different kind of thrombosis. So genotype and phenotype relationship is very important. What I have mentioned earlier that the beta globin gene, if the patient both gene has beta plus, then there will be some form of the hemoglobin A will be there. But if the patient has both side beta zero mutation, then there will be no hemoglobin A. So there will be severe thalassemia or beta thalassemia major will be there. On the other hand, you can see that in case of alpha thalassemia, I don't know why the pointer is not pointing towards the floor. But in case of bursts of hemoglobin hydrospecialis, where all four of the alpha genes are deleted, this is not compatible with life, and this is not livable condition. They usually die in the ether. But hemoglobin H, when one alpha gene is present, but there is three alpha genes are deleted, then hemoglobin H disease, which is thalassemia intermedia-like presentation. So next is that all this leads to the phenotypic classification, that is the TDT, that is transfusion dependent thalassemia, which requires regular blood transfusion to survive, and without adequate blood transfusion support, they would suffer with several complications and a short lifespan. So this category includes patient with beta thalassemia major, the severe hemoglobin E beta thalassemia, and hemoglobin H disease sometimes, but H disease is mostly regarded as NTDT, that is the non-transfusion dependent thalassemia. They need the transfusion but not regular. So this is the clinical features. The patients with thalassemia major typically present with the hepatosplenomegaly, hemolytic anemia, jaundice, and they require the regular blood transfusion, and for that reason they have the iron overload that will cause some more complication like cardiac failure, cirrhosis, and the diabetes mellitus, like other and also the other endocrine problems. And there are bony changes making this patient. You can see that there are malocclusion of teeth and other bony changes in their faces. So this is a boy of 20-year male from the North Bengal who has the severe growth retardation. Yes, he's a boy of 20 years but looks like 10 years. His facial and bony changes are apparent, and the hepatosplenomegaly can be visible from outside. And the seldom he received transfusion since his childhood, meaning he was inappropriately transfused. So after giving regular monthly transfusion, that was after 17 years of his age. So what we would regard him or classify this patient, whether as because he didn't took the transfusion, whether he is non-transfusion dependent thalassemia or he is transfusion dependent thalassemia. If you can take in the conversation. So any one of you, if you can join, whether it is classification of thalassemia, whether it is transfusion dependent or non-transfusion dependent. Anyone want to contribute? So definitely he's transfusion dependent thalassemia because he was not properly transfused, but he required inappropriately, he was not transfused. So next case is 38-year-old man with thalassemia intermedia. This is not man, it's female. 6 weeks history of progressive, this is a man. So this is 38-year-old man with thalassemia intermedia who was known case for thalassemia. 6 weeks history of progressive muscle weakness, back pain, and the paresthesia in the legs. And on examination, there was hepatosplenomegaly. The neurological examination revealed there was bilateral features of the cord compression. So this was his X-ray, and this is the MRI. It's showing that his X-ray, chest X-ray shows the lobulated soft tissue in the posterior mediastinal masses, and medullary expansion was seen. So this was a case of the extramedullary hemopoiesis causing the cord compression. It is a rare presentation, but can happen in case of thalassemia, especially thalassemia intermedia-like patients. So management usually required for this cord compression, this sort of cord compression, steroid, radiotherapy, and surgical removal. This patient, she is a young female, and this is the hemoglobin electrophoresis is showing. She with her parents. The electrophoresis was done when she was 16 years of age, and she had severe, huge splenomegaly, but she never had any kind of blood transfusion before. And then what we found that her growth is normal, but her electrophoresis showed she had beta thalassemia major. But why this patient did not have developed any sort of growth retardation, in spite that she didn't take any transfusion. So there are some other pathologies. If you can see that, see the electrophoresis, you see that here the hemoglobin A is 18, only 2.6. Sorry, hemoglobin F is 89%, hemoglobin A is 8%, which is much lower than normal, and A2 is normal. This indicates patient may have or patient might have concurrent alpha thalassemia, because this is the genetic modifier of the phenotype. Phenotypically, she is non-transfusion dependent, but actually her disease genotype looks like she is beta thalassemia major with transfusion dependent or major thalassemia. So this is why she grew up like a normal person. And after having the splenectomy, she never had blood transfusion, or very rarely she took the blood transfusion. Second, 30-year male patient presented with a persistent jaundice since childhood, otherwise he was healthy. Indirect bilirubin was higher and splenomegaly was there. Hemoglobin electrophoresis showed E beta thalassemia. He never took any sort of blood transfusion in his life, but his hemoglobin is 8.5 to 9.5 gram per ml at steady state. So E beta thalassemia may present as thalassemia major, may present as minor also, and this is the presentation of the TDT, that is the non-transfusion dependent thalassemia like presentation. Again, a case of 32-year female of E beta thalassemia. I'm talking more about the E beta thalassemia because this is the commonest in our country. So she had history of regular monthly transfusion since her early childhood at 10 months of her age. So she is regarded as TDT for 25 years of her life. And splenectomy was done at 12 years of her age, and she had severe iron overload. And for last 7 years, she is on some medicines like thalidomide and hydroxyurea. And gradually, transfusion requirement was decreasing. That is the 3 to 4 times per year. When it was since birth, it was regularly or monthly transfusion, even 15 days apart transfusion. And finally, she achieved non-transfusion dependence on 2023 and 24. And finally, she got married in 24. And when she was planning for pregnancy, we stopped the thalidomide due to pregnancy planning. And again, she became transfusion dependent. So there are some genetic modifiers as well as there are some medication that makes the patient or turns the patient TDT to MTDT and again to TDT. So how we usually diagnose, this is very simple. CBC and peripheral blood film shows microcytic hypobolic blood film. In case of only thalassemia carrier, but this is the picture of the thalassemia syndrome or thalassemia disease, which shows anisocytosis. Specific slide of that patient who had TDT come back after NTDT. After splenectomy, there are plenty of nucleated red cell can be seen. So we can also do the hemoglobin electrophoresis after doing the CBC and PPF that reveal microcytic hypoglobic blood picture. Then DNA test in some cases, and finally prenatal DNA diagnosis test can also be done. I think Professor Kalur sir is there for appropriate talking on this. So again, I would like to interpret if there is any person from the laboratory. So is there any laboratory medicine or there is there? Thank you. So we can assume that hemoglobin A is 29%, hemoglobin F is 70.7%, and A2 is 0.3%. What could be the interpretation? Anyone can join. Here you can see that hemoglobin F, which is not normally present in adult. Here, this is constitutes the 70%. Sir, do you want to have any comment on this?
Thalassemia.
Beta thalassemia, right? Beta thalassemia. But when we see this kind of report, we must look at the age of this patient. Because this is a patient of 7 months. And for 7 months or newborn, this is normal. This was a picture of newborn to 3 months of age. So if this patient has less than 1 year of age, this is the normal picture. So this may misreported as thalassemia major many times. Parents আমাদের কাছে আসে রিপোর্ট নিয়ে তখন আমাদেরকে আসলে দেখে বলতে হয় যে এটা
But
sometimes
are you going to do this hemoglobin electrophoresis without doing TBF?
I'm just taking that this slide because hemoglobin electrophoresis is
Hemoglobin electrophoresis, then it is.
yes.
Sometimes
I'm talking this point because it is written as thalassemia major, but we have to incorporate that CBC report. Sir rightly mentioned that CBC report should be considered. Age of the patient should be considered before giving any comment. And finally, transfusion history has to be taken also. And sometimes we need the family history also for doing making a right comment for the patient. So that's why I give this slide. So one DNA test is necessary. So DNA test is necessary to confirm the disease and for the alpha thalassemia and prenatal diagnosis when one couple is beta thalassemia and other one is A beta disease or E3 or beta or liver or other variants. So this is a glimpse of transfusion and other management for the thalassemia patient, which is a comprehensive team approach. We need not only the hematologist, we need the transfusion specialist, blood transfusion, medicine, laboratory investigations, capability and facilities, and the counseling for the patient and managing all the complications related to the thalassemia and iron overload. So evaluation of the iron overload needs simply can do by the serum creatine concentration, and the liver iron concentration can be seen by the dry weight of the liver, but it can be done by the MRI also. So MRI or PET scan, which is a non-invasive procedure. These are the chelation medication. There are 3 chelation medication, 3 groups of medication. All are available in Bangladesh. But recently we are moving more in the deferracilux, which is the oral chelator. So you can see both patient. In the right side, the patient is well transfused. That's why she has no bony changes or apparently healthy looking, but she needs transfusion regularly that prevents the patient from making any bony changes. But on the other side, this boy, I have shown you that he has growth retardation at the 20 years of age, who was not transfused, and inappropriate transfusion may lead this. But beneficial effect of the transfusion is that overall survival and the ultimate quality of life is much better in case of regular transfusion. This is the anti-glass treatment, all treatment. If we can intervene the globin gene imbalance by giving the patient gene therapy, which is rarely being done because this is under consideration or under clinical trial. But there are some medications like thalidomide, hydroxyurea. This can reduce the globin chain imbalance. Then ineffective erythropoiesis. There are some drugs causing less ineffective erythropoiesis, like resortib, luspatercept, or this kind of drugs. And we must give patients always goal that I have shown you that blood transfusion. Blood transfusion is mandatory for all patients. And in addition to blood transfusion, when the patient has developed iron overload, we must take the iron chelating agents. But what is the curative approach? Curative approach is our allogenic bone marrow transplantation. So goal of transfusion or is the use of component therapy. I think this hospital uses component therapy. So inappropriate transfusion, but maintain and ensure sufficient oxygen transport and lipo-reduced red cell concentrate is the ideal to give. And target hemoglobin depend on the clinical situation, whether this is baby, whether this is pregnant. Like in case of pregnancy, we want to maintain 10 or more hemoglobin, 10 or 10 gram per TL or more. Or in case of kids, that is, we want to maintain for the growth, prevent the growth retardation or to ensure the growth, that is 9 to 10.5 gram per TL. There are certain complications may happen due to iron overload, like cardiovascular disease, liver disease, growth retardation, or other endocrine disease, infectious complication, bone disease, infertility, and thrombosis. So there are several endocrine complications may happen in case of thalassemia major and intermediate patient, starting from the hypogonadism and the short stature and the glycemic abnormalities, hypoparathyroidism, or hypothyroidism. I have already mentioned that the only curative treatment is the allogeneic bone marrow transplantation, which the outcome is more than 80% are best for the younger individual who have undergone rigorous iron chelation with the transfusion and iron chelation. Here I have shown two study results. The left one is from the India study and the right one is from the China group study. They both have shown that hematopoietic stem cell transplantation outcome in patients with the thalassemia major. In this case, the overall survival is almost 84%, and the China reported as 92% overall survival rate. And the thalassemia-free survival is 90%, meaning that, stating that this allogeneic stem cell transplantation has very good outcome in case of good thalassemia patient with good donor who has at least good donor. What is good donor? Meaning you can see that the matched sibling donor has the much better outcome. It is Shirson. Matched sibling donor has the much better outcome than other donor. So this slide I will give for the gynecologist and obstetrician here. They must present or who are listening. The 20-year female 12 weeks pregnancy came with the report of the beta thalassemia carrier. And her husband is also a beta thalassemia carrier. So what will be their approach? How to do the antenatal DNA sampling, and Sir will deeply concerned about this detail. So take home message is genotype leads to the phenotype of the thalassemia, diagnosis leads not only the hemoglobin electrophoresis, but also the history, CBC, and the DNA test in some cases. And for hemoglobin electrophoresis, we need to make the patient transfusion free for at least 3 months. And the TDT and NTDT may switch to each other over time. And the judicious and appropriate transfusion and proper chelation can increase the overall survival. And screening test before marriage is an effective way of prevention. Much preventive talk will be given by the professor in the answer. And allogenic HSCT, which is the best curative option for the treatment. So this is my further reading. Thank you very much for giving me the opportunity. Happy to take your question.
Thank you, ma'am, for your valuable presentation. Now I would like to kindly invite our next keynote speaker, Professor Dr. M. Khan sir, who will discuss thalassemia prevention, time to build a social movement. Sir, please come to this.
Friends, gentlemen, senior and junior colleagues, and respected chairperson, and panel of expert. Assalamu alaikum. Dr. Mafra already covered all the aspect of thalassemia. I just take 10 minutes to highlight something. Uh, yeah. Last word of the Mafra said that the component confusion যেটা হচ্ছিল আমাদের গাইনোকোলজি সার্জারি সার্জনটা সবচেয়ে বেশি কম্পোনেন্ট ব্লাড ইউজ করে তাদেরকে রিকোয়েস্ট থাকবে যে তারা যেন কম্পোনেন্ট ইউজ করে হোল ব্লাড কনফিউশন আজকাল অ্যাবসলিউট হয়ে গেছে তারপরে হচ্ছে রিকমেন্ডেশন হচ্ছে হোয়াই টু নিড blood you advise component I mean RBC or plasma or platelet like that and we have that facility in our hospital. Thank you. And no conflict of interest. I just highlight thalassemia prevalence, outline of thalassemia prevention, factors stories, and budgeting for prevention. WHO Health Bulletin 2008 found that there is a failure in Bangladesh 7%. But in 2024, there's a nationwide survey done by Bangladesh Bureau of Statistics. It's a government organization and in collaboration with Thalassemia Committee. And we found that total failure in Bangladesh is 11.4, huge, and about 2 crore of population having the failure. So, and every year there is a 11 to 12,000 they born with thalassemia. So, and also interesting finding we in the study that zone wise, that is divisional wise, in the Rangpur is very alarming data, 27.7% failure. It is out of 4, 1 is failure. We have the particular education child by so it is very alarming. And in Dhaka, because mixed population there is 8.6 failure, and in Sylhet, my home place, only 4.8% failure. So we should oh yes, I am. Last year in the meeting, I was বলছিলাম যে good candidate for. So it is surprising in the developing country, only 10% thalassemia patient can get access to standard medical treatment. So even in our country, developing country, cannot all the patients can get the standard medical treatment. And for the treatment purpose, about 3 lakh taka needed per year. So this needed, and all the taka is from patient pocket. So yearly, about 60,000 patients need 1,800 crore per annum. So huge budget needed for the treatment purpose. So basically, for treatment, first line treatment is blood transfusion, started at the age of the 1 year or 6 months. And after that, after transfusion, 10 or 20 bed blood, or after 2 years, there's a huge iron overload. Because when we transfuse 1 unit, there's a input 200 milligram. And after the byproduct of the iron, only 1 milligram iron escaped from the body. There is no other organ to escape as much iron eliminate. So 200 days needed to eliminate the iron which is given in the body. So patient need iron chelation because iron is deposited in the vital organ like liver, like heart, and some endocrine organ, and gradually they become dysfunctional. In the treatment, we also use some medication like hydroxyurea, very common drug. রোগীরা অনেক সময় বলে ফার্মেসিতে বলে
এটা তো ক্যান্সারের ড্রাগ দিচ্ছে স্যার তো it has multi-purpose function and another drug is thalidomide immune modulated drug which are hemoglobin inducer because in the hemoglobin there is a four globin protein and when it is beta globin is used to four to alpha is excess and to so that the excess alpha is deposited and red cell is ineffective and die early. New drug available in the Western country, but not in our country. This Luspatercept is costly. It needs one dose about 60,000 taka. Because 1 milligram per kg body weight it should give subcutaneously, but not for children. It is given from the age of 18 years. Splenectomy. Pediatric surgeon is there. I invite. I'm WYK. That was splenectomy. Sometimes needed. My spleen is hugely enlarged, and even sometimes severe pain. Splenic infarct. So it is useless. So it should be splenectomy. So is there any curative treatment? All the curative treatment is curative treatment allogeneic bone marrow transplantation. We have started transplant in Bangladesh in 2014, but mostly we are doing treatment for leukemia patient because আমি যদি বলি যে একটা রোগী চাই ট্রান্সপ্লান্টের জন্য it's very difficult to find the patient because they have iron not well chelated, they have no donor, they have no good liver. So it is difficult to find the patient with good donor. But definitely, according to 2012 NRI study, allogeneic stem cell transplantation was cost effective compared to standard medical treatment. Because medical treatment needs whole life treatment, and but allogeneic transplant only need once, and it is at a time about 15 lakh or 20 lakhs. But there is a no transmission after transplant. So this is a story. We always select low risk patient, that is adequate chelating done, no hepatomegaly, no liver fibrosis. It is a good patient for good transplant outcome. And overall survival is 94%. And thalassemia-free survival is 87%. So we should go for transplant if we have good patient. Stem cell, we not go for detail. When we collect stem cell collect from the blood, from the bone marrow, or umbilical cord blood. Usually we are in Bangladesh, we collect or mostly everybody collect from the peripheral blood. But stem cell not remain in the circulation. But how we push them? We give some medicine and push the stem cell in the circulation. We just find the number of the stem cell. If adequate, then collect like platelet collection and preserve it. It's a very simple way. I have opportunity to collect stem cell in 2017 in Anwar Khan Modern Hospital. After cesarean section, we collect the stem cell. That is just cord blood. Collect and preserve cell preservation in 2017. So in the 2008, the 7%, and 2024, there is a 11.4% area. Next, if I told the we should do something, and the policy recommendation for prevention, population area detection is very low. Who are the target? We cannot do area for the whole 17 people. We must target the school and college students. Even we may make a law for entry point, we can ask to do screening program that CBC, just simple CBC and hemoglobin electrophoresis. And before marriage, and the family who have no area. Family screening program. After that, premarital screening and genetic counsel. যাদের বিবাহের পূর্বে আমরা বলে থাকি করতে হবে, বাট ইট ইজ নট ম্যান্ডেটরি টু ম্যারি। আপনি যদি চাইলে করতে পারেন থ্যালাসেমিয়া ক্যারিয়ারকে, কাউন্সেলিং আপনি জেনে শুনে বিয়ে করেন একজন ক্যারিয়ারকে, নো প্রবলেম। বাট there is a in many countries, Iran and Muslim countries like Saudi Arabia, there's a law, compulsory law should do electrophoresis before marriage. আপনি বিয়ে করেন অসুবিধা নেই, কিন্তু আমরা জানতে হবে আপনি হ্যাঁ একটা ক্যারিয়ারকে বিয়ে করছেন। Prenatal diagnosis, যাদের এখান থেকে স্টেপ হয়ে যাবে, যাদের both husband wife is failure, তাদের prenatal diagnosis is very important medically to prevent effect of baby, যাতে thalassemia baby যাতে জন্মগ্রহণ না করে। Public awareness and education is very important. সৌদি আরবে একটা স্টাডিতে করে দেখা গিয়েছে যে তাদের এখানে বিয়ের আগে ম্যান্ডেটরি, ইভেন দেন 60% ফ্যামিলি যারা জানে না যে তাদের এই জন্য তারা এই চেষ্টা করতেছে। সো অ্যাওয়ারনেস এন্ড এডুকেশন ইজ ভেরি ইম্পর্টেন্ট টু মেক সাকসেসফুল দ্য program. So, national সার্ভেতে আমাদের দেশে দেখা গেছে ইউনিভার্সিটি স্টুডেন্টরা 80% জানে না যে থ্যালাসেমিয়া কি, এটা একজন ক্যারিয়ারকে বিয়ে করলে কি হতে পারে। সো আমাদেরকে এই জিনিসগুলা বেশি করে প্রচার করতে হবে, এবং এই প্রচারের দায়িত্বটা পড়ে যায় ডাক্তারদের উপরে। বিকজ ডক্টর এখানে উদ্দেশ্য হলো ইউ হ্যাভ এম দ্যাট ডক্টর শুড নো যে কনসিকুয়েন্স কি হতে পারে, হোয়াট টু ডু, আমরা কি তাদেরকে বুঝাবো। কারণ আমরা জানি এভরিডে আমরা কোনো না কোনো দিন একটা ক্যারিয়ারকে আমরা আমাদের হাত দিয়ে যাচ্ছে। So we should fight on the career and then scaling the family. So the national thalassemia registry is very important. আমরা যে টার্গেট হচ্ছে almost 0 thalassemia baby. But the cyber stories, তারা once in cyber there is 33% failure, but now it is come to 0. In 1976 they started prevention career detection program in the high risk group. In 1980, they started premarital screening was made compulsory by law. And after that, 1984, prenatal diagnosis and genetic counseling law. Yeah. And then 1991 to 2001, there's only 5 thalassemia baby born. এরপরে last 5 years তাদের কোনো thalassemia baby জন্মগ্রহণ করে নাই। It's not easy matter, but if we start now, it will take 5 to 10 years. Like huge eventually. Just budgeting. কিন্তু আপনি শুধু প্রেগনেন্ট মহিলা নিয়ে চিন্তা করি, তার কি পরিমাণ টাকা দরকার হয় সেটা দেখেন। Screening all the women in our country, about 20 lakhs women every year pregnant. তাদেরকে যারা প্রথমবার প্রেগনেন্ট হচ্ছে তাদেরকে যদি আমরা স্ক্রিনিং এর আওতা আনি, তাহলে we need 405 crore টাকা। Yes, and we try to meet our minister and give this program. Women found to be career about the এই মধ্যে আমরা ক্যারিয়ার পাবো 3,18,000, এবং যেহেতু ক্যারিয়ারটা আমরা ডিটেক্ট করেছি আবার পার্টনারকে আমরা তখন ক্যারিয়ার ইয়ে করতে হবে, স্ক্রিনিং প্রোগ্রামে আনতে হবে। অর্থাৎ 318,600 হাজবেন্ড এবং 48 crore টাকা অনলি। দেন এই যে ক্যারিয়ার আমাদের বিয়ে হয়ে গেল, about 44,000 couples, এদের বেলায় যখন হবে then we need to do prenatal diagnosis. এর জন্য লাগবে প্রায় 110 কোটি টাকা, বিকজ প্রতিটা প্রিনেটাল টেস্টে 25,000 টাকার মতো লাগে। আমাদের গাইনোকোলজিস্ট আছেন, ওনারা অ্যামনিওটিক ফ্লুইড বাইর করে দেন, ওটাকে ডিএনএ টেস্ট করা হয়, মিনিমাম 25,000, ওরা কম পয়সা এটা করে দেয়, এটা আরো বেশি লাগে। তো ধরলাম এই যদি হয় 110 crore টাকা নিলেন, এবং আমরা যেটাকে হুবহু ফলো করি এবং আপ টু 100% যদি সাকসেস পেতে চাই, তাহলে উই নিড 563 crore টাকা per annum. So this is the last slide. Thalassemia is not just a medical condition. It is a social challenge. এটা সবাইকে আমরা মিলে কাজ করতে হবে। Prevention is the most cost-effective strategy. Through structured screening and reproductive choice can reduce new thalassemia birth. For successful thalassemia prevention, demand collective responsibility from policymakers, health care giver, educators, community leaders, and families. and transforming awareness into action is the only way. Thank you. আমরা থ্যালাসেমিয়া সমিতি নিয়ে আমরা কাজ করে যাচ্ছি, এরকম আমাদের মতো আরো কিছু প্রতিষ্ঠান রয়েছে, we are working together, কিন্তু it is very small work in comparative to government areas হবে, আমরা যতই চিল্লাই না কেন till government take policies it is not possible. Thank you.